that I've got to roll through this and get out of here. So, my name's Tammy. I've seen most of you guys, I guess, last time, so you all know who I am. Today we're going to talk about spine. This is my baby, so from that standpoint, okay, I forget which one's which, Sally, though. This is the pointer, though, isn't it? Yeah, that's the pointer. This one moves. Yep. Okay, yeah. This is what I've done for years. So if I start going too fast, if I start babbling about something, just tell me to slow down. Because this is something I kind of know like the back of my hand, so sometimes I don't think about it. I will tell you from the standpoint of what's going on, I don't care probably whatever practice you go into, even if it's not in practice because it's your parents or your neighbor or you're walking around in the grocery store, this is something that you will deal with on a daily basis when it comes to spine pain, because it is something that we deal with all the time. It is probably one of the top money cost stuff from the standpoint in the healthcare system is dealing with low back pain and neck pain. So according to here, instance-wise, we can look through. It is the 5th most common presentation to any office. It's probably gone up now. It's probably more than that. But from the papers and stuff that initially put out, it was 1 out of every 5 person that walks in your office is walking in your office due to some kind of pain. Females more than males, probably not incidence-wise, but complaints-wise more. Women will go to the doctor for this more. More prevalent in that kind of 40 to 60s. You'll get the young ones that have that acute herniated disc, but most of the time this is going to be kind of your middle-aged person. Who's it affect most and how does it get most reported? People with sedentary lifestyles, the people that sit around and don't do much, that aren't exercising, that aren't fit, people that work in manual labor jobs. So, you're out working, you get it a lot here because of all the guys coming in off of the pipelines and stuff that have been out working in the oil fields. Their backs are just trash. Lower economic status, again, lower education, smoking status. It's another one of those things that, my patients yell at me continuously. It's like, I didn't think I would come to the spine doctor and he would holler at me about smoking. I thought that's where my primary care doctor, told me that I can't, what has it got to do with my spine? Well, we know that it causes osteoporosis. We know that it causes degenerative changes in the discs. We know that it causes all the problems that are associated with low back pain. And then later on, we know that if a patient needs surgery or needs things from a standpoint, it decreases the fusion rate, it decreases your healing. So from that standpoint, just one more reason to continue to harp on your patients about smoking. Body habitus, big one. Particularly now that they say that more than half of the population are obese. You put more weight on your body. Guess what? Your spine doesn't like it. So from that standpoint, those are things that we all have to watch out for. An impact that it makes on society. The number one work-related work comp claim. If you deal with anything in work comp, they have entire clinics out there that a lot of PAs work at. But they have a lot of clinics out there that just deal with workman's compensation claims. And of those, they're almost more than 70% of those that will come through that are going to be complaining of back and neck pain. So that's from that. Also, the number one cause of people who are filing permanent disability claims. So people who are filing for Social Security and for filing for permanent disability before the age of when they should be filing for Social Security, they're trying because of back pain. So that's coming through. Also, the number 2 cause for missed employment days. So again, You know, high impact on society, high impact on costs, not only healthcare costs, but also business costs. Obviously, when you're looking at things, anytime you look at things with regards to physiology of something, you know, you can't ignore the anatomy. I mean, if something's going on with anatomy, that's what's probably the cause of the pain. So, you know, just reviewing quickly over kind of the anatomy of what we're looking at in the spine. Obviously, you've got cervical, thoracic, lumbar, sacral, coccyx. So, you know, everybody kind of knows the general layout of the spine. The biggest ones that you're going to deal with the majority of the time from a pain standpoint is going to run into kind of the cervical region or the lumbar region. Okay, remember your thoracic region is attached to your ribs and stuff, so very little discs. I mean, the discs in there are teeny tiny, so the effect of herniating those discs is not really going to cause much of a complaint. But when we start looking at all of those, what we want to look for initially is the structure of the spine. The spine's set up a specific way to maintain the structure of the body. So you have a normal cervical lordosis going into a thoracic kyphosis, going back into a lumbar lordosis. That curvature is necessary. And when we have alterations in that curvature, whether you've got a straightening of the cervical spine or even a reverse lordosis of the cervical spine, or a straightening of the lumbar spine, or a hyperlordosis of the lumbar spine, all of that actual structure in the spine can then be related to the cause of the pain. So we've got to look at the structure first and determine, is there something going on there that's resulting in the problem. Then when you break that down even further, then you look at the fact of the actual structure of the spine itself. Lots of components to the structure of the spine, so lots of things that can happen to it. Spinous processes, obviously you know what these are, the backbone itself. The biggest thing that we worry about is not necessarily the spinous process itself, but the ligaments that run between the spinous processes. You know, if we have problems in the ligaments that are here from a trauma or things from there, we're going to have issues and pain associated here. What else can we talk about? Spinous process, lamina. Lamina is the connection between the spinous process and the transverse process here. Lots of issues that can happen in the lamina, particularly as you get over into this area that is between the superior articular facet and the inferior articular facet, which is the facet, which is the joint of the spine, which causes the movement of the spine. There's an area that runs right in through here that's called the pars. Okay, the pars is, if anybody's ever heard that somebody's had a pars fracture, comes in from this area right through here. People can be born with pars fractures. Or a pars defect. It's not uncommon for that to happen. Happens a lot in sports-related injuries. Happens a lot in automobile injuries, things like that. That if we get a fracture line through here, we can have some problems that we'll talk about along the way. So that's an area that we've got to look at. Transverse processes out here, a lot of times, particularly in a fall, somebody's fallen out of a tree, somebody's gotten involved in a kind of a high-speed car accident, those type of things. You'll see a lot of fractures off of transverse processes. Ignore them, don't worry about them. Yes, they hurt, but they'll heal, they're fine. Usually the pain is because there's ligaments that go between the transverse process this way and the transverse process between one to the other. So you're going to get a ligament injury, so that's going to be sore. But it's not a surgical need. There's nothing that we have to worry about too much with it. The pedicle, this is the region that basically connects what we call the posterior elements with the anterior elements. Again, you know, that's the biggest issue here that you will see a lot. People can have congenitally shortened pedicles. What does that mean? You know, it just means that you were just born and instead of them being this long, they were this long. Okay. The importance of that is that defines how big this hole can be. That hole's where your spinal column is going to sit. So if the pedicles are congenitally shortened, and you've got a smaller space from that, and then you've got other things, you've got a disc herniation or you've got something else that's poking out into this area, then we're going to start getting cord compression or spinal canal compression. So pedicles really nothing that you all worry about. We worry about them every day because of surgery, because we've got to be able to hit those pedicles with screws. But it can affect what's going on here. So somebody who might not have a disc herniation that you really think is that bad, doesn't look that bad, but if their pedicles are already short, you know, that just took that hole that's this big around and it made it this big around, and they're having claudication symptoms because of it. Vertebral body, of course, you know, it's the bone. Nothing more you can say about it. The disc, here in between each one of the bones. Best way I try to explain it to my patients is it's a shock absorber on your car. You know, if it's hydrated and it's working good and things are going well, it's a nice smooth ride. The minute we lose the hydration, the minute we have problems with that your shock absorbers are, you know, horrible on your car. So from that standpoint, we'll talk a little bit more about the disc, but discs are an area that you will run into all the time. And no matter, people will come in and tell you, they'll say, oh, you know, I've been told all along that I've got degenerative disc disease. Okay? We all have degenerative disc disease. Some of us worse than others. Some of us, I saw an 80-year-old the other day in the clinic who had the best looking spine I've ever seen. I mean, better than some 20-year-old. She was a long-term smoker. I mean, everything. I was like, I can't explain it. I don't know. But, you know, you'll see a wide range of what's going on. Just because their discs are dehydrated or their discs don't look good doesn't mean they have pain. Because every single one of you in here, I can guarantee, probably has some form of disc degeneration or disc dehydration, and you've never maybe had a day of back pain in your life. So from that, discs aren't something that just because somebody says I have a degenerative disc doesn't mean, hey, we better send you to the surgeon because, you know, we've got to get this fixed. People who have degenerative discs and have back pain only, and you send them for surgery, will be back in your office again with back pain. Okay? So very few people do well with spine surgery due to discogenic pain alone. That's not everybody, but very few. As usual, you know, I can't explain enough. If somebody comes in your office, you can pretty much do a good physical exam on somebody. And if you do a good physical exam on somebody, most of the time, you're not going to need any imaging to determine what's going on if you've done a good exam. But if you haven't done a good exam, then you jump straight to the fact that, oh, he's got back pain, we better go get an MRI. You know, you're going to probably do your patient more detriment than you are good, because you're going to find something in an MRI that you didn't want to find and that your patient may not want to even deal with. So do a physical exam, make sure things are going on. If there's something that neurologically or something that's looking bad, then yeah, you've got to kind of jump to that next level. But if not, treat them conservatively for a while, see what you can do to get it back. And we'll talk about the red flags, and those you don't want to miss. But these, I won't go over dermatomes with you because, I mean, I'm sure you have gone over them ad nauseum. But the biggest thing that we have in the office that come through is somebody comes in complaining of pain sitting right in here. So it's this pain that hits right here. You know, I'm hurting right here between my shoulder blades. It comes off across the top of my shoulders, and I'm hurting right here. Of those patients that come in out of primary care offices in the state of Oklahoma, probably in our office alone, I'd say probably 75% of them will come in with a thoracic MRI. Okay? They will, their primary care doctor will give them a thoracic MRI. Well, because it's right here. That's their thoracic region. Okay? They don't know their dermatomes. You know, if you know your dermatomes, you know what's going on, hitting right in this region right through here is going to be a mid-cervical problem. So, you know, remember your anatomy to know what's going on. And just because it's hurting between their shoulder blades doesn't mean that they've got a herniated disc in their thoracic spine. Okay? Remember on your thoracic dermatomes that even though they start up here in the back, remember they're going to follow a rib line. So what are they going to do when they come around the front? They're going to come down. Okay? So nipple line T4, umbilicus T10. Okay? So kind of remember those type of things, and then that will help you guide to where you're looking for on what's going on. So that's as far as I'll go on that. I hate dermatomes. Ooh, I hate these too. Again, physical exam with regards to what's going on. If you know what nerve root hits what muscle, so they come in saying their biceps are hurting, and you do deep tendon reflex on the biceps, or you actually see that their biceps are, one's atrophied versus the other one's noticeably smaller than the other ones, then you're going to know where you're starting to look. So if you get an MRI on that patient and there's nothing going wrong between C4-5, C5-6 in that area that's going to catch that C5 nerve root as it comes through, then something else is going on, and you better go find out why that person's got denervation coming to their bicep, okay? But knowing all of this and knowing where these go and what reflex hits what, the hardest one is that, hang on, I think it's the next one. This is the one that gets everybody. L4-5 is probably the most common area that we will see problems with, mostly younger people, but that will have disc problems and stuff. And there's no deep tendon reflex for that, okay? So, so when you're looking for something that says, oh, they don't have a deep tendon reflex, but the big one on that is going to be your big toe, okay? So it's going to be weakness in that big toe. Your ability to toe up, come up on your feet. As one, your ability to walk on your heels, those type of things. So looking at these type of things, you'll be able to see what's going on. This is a big one that we'll see. We'll talk a little bit more when we're coming through. Is going to be foot drop. So that patient that comes in and they're sitting, you have them sit on the bed or whatever, and you're looking, and their feet should be able to hold their feet like this, and you got one that's doing this. Or you've got the person that's coming through and you look at the toes of their shoes, and they've got the big work boots on, and that one toe is totally scuffed up. And you go, well, do you trip all the time when you're trying to walk up steps? Is something going on? Are you tripping over your own feet? Because foot drop is something that is very hard to treat conservatively without going in surgically and trying to do it. And even surgically, they're not going to get a lot of that back. So, so watch for foot drop, and we'll talk a little bit more about that. It's on here later. Again, right back to the whole history of physical. Watch where things are. Where's the location? How long is this? How often does this happen? Is it something that bothers them every day and is constant, or is it come and go? Those type of things we'll figure out, as you go along, as to how in depth the treatment. If it's somebody that was playing golf yesterday and they hurt today, well, likelihood is that they do some stretching exercises, they do some things. Oh, that's another thing. Old wives' tale. You hurt your back and go lay down for a week? No. Okay? And you'll find a lot of people that'll say, well, I went to see my doctor. My doctor told me to not do anything for a week, and the pain just hasn't gone away. Well, no, it's not going to. We have to modify what you do. We have to do some activity modification and some stretching and some things like that. But the old wives' tale of, I injured my back, I'm going to lay around for 2 weeks and it'll get better, that doesn't work. Duration, again, this is something that we have to watch for. When you look at something, is it acute? Is it something that's happened over the last just couple of weeks? Is it, you know, coming more into that chronic stage where it's more than 3 or 4 months that this person has had problems? Duration is going to fall in another one we talk about stenosis, because when you look at spinal stenosis, that's something that's occurred over years, and I'll tell you a story as we get into that area. Previous history is the person had back pain before, and it got better, and now they got back pain again. You know, those type of things. You know, if you had it before, how'd you treat it? You know, if you had it before, it went away. How did it go away last time? Can we make it go away this time before we go from there? And then the big thing is are they having any radicular symptoms? So, you know, if they're having discogenic pain, or if they're having a compression fracture in the vertebral spine or something, pain's going to be localized. I mean, it's going to be, they're going to be able to, you know, a lot of times they'll take you because they can't get to it. They'll take you and turn you around and they say, it hurts right here, okay? But if it's a nerve root issue, if we've got something that's damaging or actually impinging a nerve root, it's got to go. It's got to go into more of a radicular pattern here. The thing is have them take one finger and trace where that pain is. So one finger. Don't do this. Don't have them come in. We do, and I can't stand it, but we have a spine front and back, you know, a little stick figure person, and you know, and it's got put an X for, you know, numbness, and put a circle for pain, and put a dash for I don't know what all. So Sal, you remember what's all on there? I don't know, but I look at that picture. I can't tell you the number of them that I have on my phone that I've taken pictures of them, you know, in the office. It doesn't have any identifying features on it, so it's not HIPAA. But I mean, it is all over. I mean, these people come in and they've got X's and check marks and, you know, squiggly lines and great big circles, and I mean, some of the things, I mean, little notes in the corners. I mean, it must have taken you 45 minutes to fill out this diagram. So, but when they get into your office, have them take one finger and show you where it hurts, okay? Because if it's following a true nerve root pattern, their finger will follow that nerve root. They will come in and go, oh, it comes across here, hits down through here, comes across here, and these 2 fingers are numb. Okay, bingo. I mean, they just followed a nerve root. So have them follow that nerve root for you. They just did half your work. These are the ones that you don't want to miss, okay? So that person that comes in the office and you got through all of this thing and you're like, oh, it's really no big deal, okay? But what you haven't paid attention to is, you know, maybe they've recently had a big infection of something that's going on. You know, maybe they've been really sick, or they've been in the hospital recently for a sepsis, for a urinary tract infection. I mean, it's just weird stuff like that comes through. And now they have a raging epidural abscess, or they have a raging osteomyelitis or discitis. You know, those type of things. So you have to kind of always keep these things in the back of your head as you're looking through their history to make sure that you don't just, it's just a little back pain, blow it off and go. So those people that are older, those people who know have osteoporosis, who all of a sudden, they don't have to have had a fall. They could have sneezed and caused a compression fracture, okay? So anybody that you know that has a history of this, people that follow in that realm as well, long-term steroid users. So your patient that comes in who has RA and their rheumatologist has had them on 60 milligrams of prednisone for 15 years, you know, their bones are going to be trash. So keeping that in mind. Somebody who comes in with a high fever, I mean, you know, are we dealing with a septic issue, recent infection, IV drug users? You know, I can guarantee you probably of the, I don't know, 15 or 16 a month that we see that come through Saints that we get consults on for osteomyelitis or discitis, they're almost always coming from IV drug. So somewhere along the line, you'll keep reading through the chart and you'll go, oh, bingo, right there. But you'll see that a lot. Obviously, if somebody's been involved in a trauma, I mean, if they're coming in with an automobile accident or whatever, you got to investigate a little bit more. Big one here. Somebody who comes in with a sudden onset of bowel or bladder dysfunction or saddle anesthesia. And we'll talk about that a little bit more. That's called Acupuncture syndrome. That's a medical emergency. That's one of our few spinal emergencies. That's one of the few things that we get the call from the ER that says that that's going on. We say, throw them in the MRI machine, call us back as soon as they get out. They call us back as soon as they get out, and literally we're already in our scrubs and usually in the car and calling in the team and on our way in. You don't fix a cauda equina soon, they'll be wearing a diaper for the rest of their lives. Okay, so this needs to be fixed. And then obviously looking at things from a standpoint, do they have a history of cancer? Or they have a recent weight loss, things like that. I can't tell you the number of times we've diagnosed colon cancer, breast cancers, lung cancers from somebody who came in with back pain. And they threw in the scanner because something didn't look right on what was going on, and there's a bone met in there, and we can use either us or one of the interventional radiologists to go in and pull biopsy out of that bone, and then we're doing whole body CTs and stuff like that, PET scans to figure out where the primary is as we're waiting on the culture, as we're waiting on the identification to come back from there. So keep that in mind too. That could be cancer. Not very often, but it can be. When you look at imaging, every single one of these tells you a different thing. Okay, patients come into to us all the time, and we try as a surgical office, we try not to see patients before they've gotten to the point of, has your primary care done things conservatively to get things to where you are, but they come in with an MRI, and the first thing we do is send them in our office and put them in an X-ray. And the patients are like, I brought an MRI. Why do I need an X-ray? Okay, every single one of these things are good imaging because they all tell you something a little different. An MRI is great for us to look at to see what's going on with the soft tissue, with the nerves, with the discs, on how things, really specifically with what's going on. But it's crappy to tell us what's going on with the bone. I mean, unless there's multiple myeloma or some big old tumor that's sitting in there, it doesn't really tell us a lot with regards to bone. It also, there's a few of them now, and you're seeing more of the standing MRIs that are out there, but there's a big difference on what a patient looks like when they're laying down and what a patient looks like when they're standing up, okay, when they weight bear. So x-rays a lot of times will tell us a lot more, and all of our patients, we just insist, I'm sorry, I know you've been in an MRI machine, but I still need an x-ray. Okay. Remember with these, I don't have to go into anymore. MRI obviously, is going to look more for that neurological end of it. So if you're seeing gross neurologic changes, if you're seeing gross atrophy someplace, if you're seeing something that obviously you want to go look at a nerve to see what's going on, don't get an x-ray, don't get a CT scan. They're not going to show you what the nerve's going on. Okay? Now, except if you can't do an MRI, then you're kind of stuck with the CT scan. CT myelograms, if you want your patient to hate you, you can send them for a CT myelogram. We don't get them I don't get them ever. Sometimes our patients will come in with them. But CT myelograms are no fun. Oh, on contrasted MRIs, if patients had two things. One is if patients had a fusion, okay, and they have hardware in, they can have an MRI. All right. So a lot of them will say, oh, I had surgery, yeah, you can't do an MRI. No, you can have an MRI, it's all right. That titanium's not going to hurt the MRI. It's not going to be pulled out through your skin. It'll be okay. But in the neck, if they've had a fusion, and you want to go back and look at it from another MRI, chances are you're probably going to have to contrast it. There's so much scatter from everything that's going on because it's such a small confined space, that a contrast is going to help you really see what's going on. In the lumbar spine, a lot bigger. The majority of the time, without contrast, we can see that. Unless you're worried about a tumor, scar tissue, something specific, an abscess, something specific that you really think that, you know, contrast is necessary, it's not always needed. And even a lot of times we'll send it and send them over to give normal MRI without contrast, and have the radiologist may come back and say, hey, you know, it's really hard for us to get those images down. You know, you might want to bring them back in contrast, and that's okay, because, you know, the contrast is not benign. So a lot of people are allergic to it. A lot of people who are diabetic and who are on metformin, you got to take them off their metformin. You know, a lot of them, anybody who has kidney problems, you know, you got to get a BUN and creatinine before you contrast anybody. So anybody who has kidney problems aren't going to be contrasted, or if they're borderline, you may throw them into kidney problems. So be careful with your use of contrast. So let's look at some of the causes of why people have problems when they come into you and hurting. The majority of them are going to fall in this category. Okay? Really, just sprains and strains. They've just injured something, hurt something, doing something. They're going to get better with time. It takes time. Be patient. You know, put them on the right medications, do the right treatments. Lots of encouragement, lots of follow-up to make sure that, you know, every 4 to 6 weeks or so that you're kind of checking on them and making sure that they're doing okay. Whiplash injuries, these are hard, because a whiplash injury, things can be done wrong, but people are going to have headaches, they may have dizziness, they may have a hard time concentrating, they may have things going on for months, 6 months, 8 months, okay? And they swear something is really wrong, and there's really nothing in it, but whiplash takes a very, very, very long time to get over. A lot of this can be handled because the patient's just doing something incorrectly, okay? You know, they're constantly like this on their phone at work all day long because they're trying to do things with their hand, and they always put their phone over here, you know? And they're always doing it, and it's like, why does this side of my neck always hurt? Well, you know, if you sit like that for 8 hours a day, it's like, you know, so how do I change that? I get a headset, get a headset to work on them, change shoulders, you know. So thinking about things and working with them and trying to figure out what are they doing inconsistently. Probably one of the biggest ones are people who are working in, you know, labor jobs that, you know, are sitting here picking up and moving things like this all the time, you know, from a standpoint. This vessel is way bigger than this one, okay? So I always tell people, you got to lift with your legs. You just got to, you know, you've got to squat down, stand up, turn the body, squat down, and put things down. If you do that, you've protected your back, you've kept your back in the normal spot, and you're not going to injure it. So, but the ones that are, you know, lifting things from here and then turning it over here and putting it back down, you do that repetitively over and over and over again, and you're going to get hurt. So, so watch that. This is the whole thing on the whole imaging again. You know, if you got a red flag, image them the minute you see them. But if you don't have a red flag, and what they're telling you is that it feels like it's something that's just kind of a repetitive stuff, don't throw them in the imaging right away. Treat them for a little bit, see how they're going to do, see what's going to happen, and then go from there. Signs and symptoms on these patients, you know, typically, you know, everything you see in here. It's a sharp pain, it hurts, they can point to it, it hurts when they move, they feel like they can't move that much, you know, they're stuck. Oh, I can't turn my head to the left, I can turn it to the right just fine, but I can't turn it to the left. There may be some swelling where they're actual muscle damage. You know, so the muscles all just upset. Again, you know, when we're looking at whiplashes too, dizziness, headaches, nausea, vomiting, difficulty concentration. One of my son's best friends up at OSU, she's a phenomenal athlete. But sometimes I really worry about her. Was studying one night really late and had one of those dusts that came out that had the doors. on the top of it, and she was underneath it. She went to do something, and she lifted her head up and smacked her head on. She'd left one of the doors open. Smacked her head on one of the doors. Knocked her out cold. I mean, just literally loss of consciousness. And she had to drop out for the rest of the semester. She had to drop out an entire semester because anytime she went into the light, anytime she tried to concentrate on something off of a computer, she would get an instantaneous headache. I mean, just instant. And I bet her mom called me 3 times a week. When is this going to stop? When is this going to stop? And I go, I don't know. Is it going to stop? Yes, it will. But I don't know when. And so she literally lost an entire semester at school because of it. So it's not benign. I had another one that had one from a car accident who has a bad family history of Alzheimer's disease. And I mean, her family was convinced that she had early Alzheimer's and that we were in trouble. So luckily I sent her to a neurologist who's retired now, but was also one of my mentors for years, but she's an Alzheimer's specialist, and said, will you evaluate her? And she couldn't believe in 6 months' time, when she did all the Alzheimer's testing with regards to the cognitive tests, and then she repeated it in 6 months, her scores were tenfold up. She had to quit her job for a while because she was bookkeeping. I mean, she did a lot of number stuff and dealt with a lot of cash, and she couldn't function long enough to deal with that, and was afraid that she was going to hurt the company because of money issues. And the family was convinced that they had done the me and 23 or whatever that stuff is on, and they all have predisposition to have Alzheimer's disease, and they thought for sure it was that. It wasn't. It was the head trauma that she had gotten from the car accident, and 6 months later she was fine. So treatment, obviously the big things that you want to head for: NSAIDs, non-steroidal anti-inflammatories, unless for some reason they can't take them. Muscle relaxants, short term, okay? A lot of times people sit there and worry about their patients getting addicted to narcotics. Watch them get addicted to muscle relaxants too. They do. And they love them, and they will continue to take them, particularly if you like to prescribe soma. Okay? So be careful with those, because you're going to have, you'll have patients that'll get just as addicted to these as they do the others. So, or a benzo. It's like, oh, they're hurting a little bit, I'm going to give them, 2 or 3 weeks worth of Valium. They'll be calling you, wanting more. So be careful with that. Steroids, the literature says no. Okay? We use them all the time. All right? Short bursts, just, get the inflammation out, see what's going to happen. You're not going to hurt anything if you're just giving them a quick burst of it, from that standpoint. But, again, the data says no, that it doesn't really do anything. Narcotics, obviously, very, very, very short term. Okay? There is no role for narcotics in chronic back pain. Now, tell that to all the several hundred pain management doctors out there that send you your patients that are coming in to talk about it, who are on fentanyl patches and long-term morphine and all this kind of stuff. But this is going to go by the wayside, and if you follow the papers and you follow the DEA and you follow the Oklahoma Board, you will see that our abilities to continue to give narcotics is just going to keep going down. Conservatively, this is your mainstay, okay? Sometimes just throwing them in a lumbar support brace. Sometimes encourage them to wear a brace at work. I mean, if they're having chronic low back pain because of what they're doing at work, talk to their HR at the company. A lot of times they're going to support the fact that they'll get them things. I have a lot of companies on people who have troubles if they sit all day long and they're at a computer all day. The companies have gone out and bought them one of those desks that will go from, sit to stand and all that kind of stuff that they can that they can alter their movements through the day. And if you can alter your movement through the day, you don't hurt. You guys, if you sit in here all day long listening to lectures and you don't ever get up because we run over and the next person comes in, by the time you get up at the end of the day, you're stiff because you haven't moved. Well, this is going to be the same thing for the workforce. So work with these people on what they're doing. I write people scripts all the time for, you know, support desks, things like that. They take it to their HR departments, and the majority of the time their HR departments will comply. If it keeps them at work and it keeps them from jacking up insurance rates because they keep going to the doctor for a $100 workstation, it's worth it. Heat, cold, that's patient preference. You know, I do tell people an initial injury in the first 48 hours, use cold, okay? But after that, I don't care if you use cold or heat. It's whatever makes you feel better. Physical therapy, even just sending them home, if you don't want to put them straight into, you know, outpatient physical therapy and all this kind of stuff, sending them home with a series of stretching exercises, things to do from there. The big ones in physical therapy, though, are looking for people who do other things. Lots of stretching exercises, ultrasound, TENS units, traction, those type of things are going to help. I don't discourage people from going to chiropractors. I do if you've had a fusion. I tell them you can go, but I want you to have them do other things, TENS units, you know, those type of things. No manipulation, no pop, snap, crackle, and pop. Okay, but you know, if you find a good chiropractor in your practice that you like and that is you have the faith in saying that if something changes in that patient's physical exam and they're seeing them all the time and all of a sudden now they come in and, you know, this whole arm is numb, you know, that chiropractor is not going to just continue to keep working on it. They're going to say, hey, look, something's changed in your physical exam. I need you to go someplace else. So just be careful with that. A lot of people, I misspelled acupuncture. I have a lot of people that utilize acupuncture, dry needling, you know, those type of things. If it works for you, great. I mean, it's not going to hurt anything. And if it works, when I was at the VA, we had a Russian neurologist that was there, and he did a bunch of acupuncture. And at first, I went, yeah, right. And so I didn't think much about it, but I went down one day, I guess in the OR, they had a patient that had horrible nausea and vomiting. I mean, just literally, you know, projectile. It was that, you know, it was that pyloric stenosis baby that, you know, projectile vomiting through across the operating room. He went down in and put in 2 needles, and that patient quit vomiting. I mean, like right there, and I went, okay, I'm a proponent. But he had, when he left, I couldn't tell you the number of patients who came to me and said, oh my God, I wish he was still here. When he was doing the acupuncture and stuff, it really helped. So again, if it works, fine. The majority of the rest of it we're going to look at is mechanical. We'll have that. If you added that up, there's still 3% left, and we'll talk about those tiny ones in a little bit. But the rest of them is going to be this. So we're talking about degenerative disease. It's just progressed as they've aged and things have gone through. And, you know, I started out, you know, I've had back pain for 40 years, you know, kind of issue, and things have just gotten worse as we go along. Congenital, were they born with it? A herniated disc or bulging disc, we'll talk about that. Spinal stenosis, and then the fractures. We'll talk about those as we go through. This is when that acute problem that you had on the muscle strain, the muscle, all that kind of stuff is now kind of turned into more chronic. Okay? This is going on for a while. I've kind of treated things are going on, and now it's just longer lasting, and we can't get this patient out of pain, and we can't get things that are going through here. So this is when we start looking, okay, it's been going on for a while. Do I need to go look at other things to figure out what's happening? Again, risk factors with regards to degenerative, same reason why we have problems with back. You know, the older I get, the more likelihood I'm going to get it. The more I smoke, the more likelihood I'm going to get it. We do know that it's linked strongly to family history. You know, my mom had back problems. My brothers and sisters had back problems. You know, I have back problems too. People who play contact sports, you'll see it. Baseball players, I see a bunch. For some reason, rowers recently. We've been seeing a rower after a rower after a rower in the office. So that happens quite a bit. Manual labor, body habitus. I mean, those type of things that you're going to see are going to lead to conditions that look like this. Okay. Things that will kind of break down as to whether or not are we talking about just discogenic pain? Is it just in the disc because the disc is dehydrated? A lot of times patients will come in and they'll say, oh, well, my MRI said that I had a tear. Okay? Annular tears, annular fissures, all that kind of stuff we see in the discs all the time. And I try to explain to them that, you know, I realize that, and that's why that disc is degenerative, and there's parts to the disc that, you know, have just been injured and things are going on. And yeah, it can be kind of like a paper cut. You know, it doesn't look very bad, but it hurts a lot. Okay? Do we go in and jump in and fix it? Not necessarily, but there are some things that we can do to try to see if we can make it better. And then if we can't, then sometimes we go in and try to fix it. Spondylosis, spondylolysis, and spondylolisthesis, we'll go over each one of those. They'll hit these terms in their MRI, and they're so funny when they come in and they try to, because they've read the report, or they'll go home and they'll have a disc, because I'll tell everybody, and make sure you tell all of your patients this too, if you send them for an MRI, don't let them leave that MRI facility without a disc in their hand, okay? The MRI facilities will print them a disc right then and there, but a lot of times they'll go, well, there's no report to it. So obviously it has to go to the radiologist has to read it, and he's not reading it on site usually. It's usually tell us something or other. Doesn't matter. Just tell them to bring the disc and hold that disc like it's gold. Because later on, if you have to take that, if you have to send them to a pain management doctor, to a surgeon, to somebody else, okay, I don't care what the report says. I mean, I don't even know in our charts how many times we have the report for what's going on. We want to see the films. Because, you know, we've just been the one. Remember, your radiologist may be reading it, but they've not examined the patient. Okay? They may have in their little history on, you know, what hurts the patient as to what's going on, but all they're responsible for is looking at the films and reading the films and telling you what they see in the pictures. But unless your picture matches your patient on the symptoms, treating the picture isn't going to do anything to the patient. Okay? So have them bring the film, have them grab the films before they leave, and make sure that they are aware of, okay, every time I send you to so-and-so, I need you to take that with you. Now, luckily, most of our offices have got to the point now where the minute they bring in a film, we can upload them into our medical records and just leave it there, so that then the next time they come back in, if they've forgotten it, it's not a big deal because we have it in, you know, we already have it in there. But it's really important that that when you send them someplace that they go with that. But in that, I guarantee you when they get home, they're going to put it in their computer, and most of them won't open. But sometimes if they have a decent enough laptop, they'll get those to open, and then they'll come in and they'll tell you that, you know, oh, I looked at it and I read the report, and you know, then they try to say all these long words. It's kind of fun. You've seen these. Remember Scotty Dog on the X-ray? Have you guys looked at X-rays? Yeah. Okay. So from the standpoint on an oblique, okay, this is what we were talking about in that whole PARS thing. Remember we talked about there being a PARS. If you have an oblique, sometimes you can see. Now, most of these, if they've had a PARS defect for a long period of time, are going to have arthritic changes that have gone along with it. And if they do, this is almost totally whited out. Like this one's a pretty nice little spot, you know, Scotty Dog here, but they're usually almost totally whited out because of the arthritic change. And actually seeing the PARS defect is pretty hard. But in this one, you can actually see that there's a break in that ear right there. So spondylolysis is a PARS defect. okay, that hasn't gone as far as spondylolisthesis, which is where there's actual movement in that vertebral body, okay? So instead of having these vertebral bodies line up here, we actually have a step off here where that is, okay? Now, this can be dynamic or it can be a stable pars fracture. If it's stable and the person looks like this, and it always has looked like that, it may not be causing them any pain at all. One of the PAs I work for has like a grade 3, and it doesn't bother them. I mean, you know, it's just, that's where it's been all along, and the body's adjusted to it, and it's fine, okay? If it's dynamic, so if you see this on an x-ray from there, the next thing you want to do is go get flexion and extension x-rays on this patient. So you have an upright that you see a spondylolisthesis, you see that it's here. If I go get a flexion and extension x-ray on it, does it change? Okay. Does that inflection, does that go from a grade 1? Remember, grade 1 is like 0 to 25%, grade 2 is 25 to 50, grade 3 is 50 to 75, grade 4, okay. So when we're looking at that, does it change? Does it move it from a grade 1 to a grade 2 inflection? Does it correct it in extension? Okay. If it's dynamic, if it's moving, okay, most of the time you got to fix those because those are going to be worse, and you're going to have a problem. So that's always something. Our X-ray techs are actually to the point now where you know they see it when we'll order a 2-view X-ray, and they'll pop their head out and say, "Hey, can you rechange that to a 4-view? I'm getting a 4-view." So you know they've looked at it before we've even seen it, and already just go ahead and get flexion and extension because they know that the next thing we're going to ask the minute we look at it is send them back over to the X-ray to do a flexion and extension. So. Treatment, not really much different than the other, okay? Smoking cessation again, you know, we go through that. You will find a lot of surgeons now, that's getting tighter and tighter. There's a lot of surgeons that won't even do surgery on patients until they've quit smoking. Here's my stance on that, okay? Actually, there's a lot of work comp that you have to quit for 6 weeks, and then they'll do a nicotine test on the patient before they'll approve the surgery. So you'll see that a lot in work comp right now. I think the last 3 work comp patients that we've had have all had to be nicotine tested before they come through. And I go in and educate the patient of they're doing it wrong, okay? Yeah, it's important that you quit smoking, right? Not because of the healing issue with the surgery, not because work comp just wants you to, okay? And I don't really care if you've quit smoking at the time we do surgery. What I care about is the year after we do surgery, for that full year. Because that's when you're fusing. That's when you're healing. That's when things are getting better. That's when things are going through. That's what smoking messes up. It doesn't mess up surgery, okay? It doesn't, just by you quitting for 6 weeks, if you've had bad bone because of smoking, it's not going to make your bone any better in 6 weeks, okay? But it's that time after surgery. So my comment to them is if you quit for 6 weeks just so that you can have surgery, and then the minute you walk out of that hospital, you light up, you hurt yourself. So I follow that up with, I'm also not following you around every day, and every time you put a cigarette in your mouth, I knock it out of your hand, okay? You have to know what this does to you. And if you know what it does to you, then hopefully you're smart enough to kick a really bad habit that is very hard to break. And I get that it's hard to break, and I understand it, okay? But this is what it does to you, and this is what happens. But I'm not going to follow you around, okay? So we are not an office that says if you quit, you know, because the chances are it's not going to happen. The chances are the minute they walk out of that hospital, they're putting a cigarette back in their mouth. Now, there are a few exceptions that quit and actually stay quit, but not very many. Second one, weight loss. You know, that's another thing. I can't tell you. I'd like to smack some of our anesthesiologists most of the time, but I can't tell you about the fact it's an ugly cycle, okay? Yeah, it would be awesome if everyone who had a BMI of 40 that had back pain, who had stenosis, who had problems or spondylolisthesis, that you said, okay, go away, lose 100 pounds, and then come back to me and we'll fix it. Okay? How do you lose weight? Besides not eating? Exercise. Okay? Well, these people, you know, if you've got a spinal stenosis and you can only walk 15 feet because your legs go numb afterwards, how am I going to get them to lose weight? A lot of those we will put in aquatic therapy programs, so we will put them in pools, we will try to get things going, we'll get them on the goal of losing weight, so that then after they feel better, we keep that going, okay? But really, when you look at this, and you know, the anesthesiologist will come in as we go to bring back surgery. There's another one that's a BMI of 42 that you're just operating their back on. Okay, well, I mean, if your back hurt, you want it fixed too. So again, you know, if it's discogenic pain and it's not radicular and we're not worried about nerve input and it's just because my back hurts, well, those people we're going to fuss at. You know, I need you to lose. And I've sent people to bariatric consults. You know, we've had insurance companies actually pay for, you know, for weight loss surgeries because, you know, they have this chronic back problem that we can't treat surgically. So, you know, the only way that they're going to get rid of it is to lose 300 pounds. And so, I mean, you know, we've done letters and stuff like that and sent notes, and we've gotten people approved for bariatric surgeries because of it. Core strengthening, big one. Okay, I can't stress enough to my patients who, well, I walk, I do all this kind of stuff, but they got a belly that's sticking out to here, you know, those type of things. So low impact exercise, swimming, yoga, Pilates, things like that that are going to really focus on core, you know, really are what we want. Bracing helps in a lot of people. I mean, you know, but the problem with bracing is I also tell them, if you wear it all the time, you're not going to strengthen your core, okay? Because it's holding your core for you, and as soon as you let go, it's like women in a corset, you know, boom, there, it's all back out again. So, yeah, if it's been a long day and things are happening and you want to brace later, that's great, but don't live in it. Physical therapy, we kind of talked about before, chiropractic, acupuncture, NSAIDs, people, NSAIDs. You know, NSAIDs have got a bad rap. So obviously you have to watch out for other things. You know, if they've got coronary artery disease, you know, they better be talking to their cardiologist and making sure it's okay with their cardiologist that they start taking NSAIDs. And, you know, but that's a communication deal. If you're a primary care physician, you know, don't forget your responsibility still is to look to see what else is going on in that patient's history. And even if you say, well, I want to put you on an NSAID, but I'm going to contact your cardiologist, or I need you to contact your cardiologist and make sure what your cardiologist has to say about it. Pain management. Boy, if you can find a good pain management doctor, buy them very nice Christmas presents. You know, keep them on your good side. Threaten your patients' lives that if they screw up that you're going to smack them, because it is hard, and it's getting harder and harder and harder to find somebody with regards to pain management. You know, you just have to look at the, you know, at the Oklahoma board every month to see the notes on the number of people who have lost their licenses because of medicine mistreatment and stuff from that, to realize that it's going to be harder and harder and harder to find a good pain management doctor. So lots of things that we can do. Some of the you know, big ones right now that they're working on, you know, some stem cell stuff that they're working on, discs, IDETs, good and bad. There's not, that's in the hands of a good pain management doctor, a good interventionalist. From there, and IDET's like a laser therapy that goes to the disc that kind of helps repair part of the discs. So promotes collagen formation and all that kind of stuff to kind of help repair the disc. So finding a good pain management doctor is really important. Obviously, hopefully, unless there's a red flag or unless there's something going on, coming to us in surgery is going to be kind of their last option. Okay, we've tried everything else, and as we've tried everything else, we can't get anything to work, and we're going to fix it. Artificial disc replacement. Patients will come in talking about it a lot right now. It's basically what we're looking at is it's a motion preservation disc. Okay, works really good in the cervical spine because there's not a lot of gravity, there's not a lot of weight in the cervical spine. The lower in the spine you go, the more weight that area has to deal with, and the less likelihood that we're having problems with it. So artificial disc replacement in lumbar spines have been kind of hit or miss as to what's going on. And most of it is because of what they're trying to do. When you look at an artificial joint, remember a disc is not a joint, okay? So your disc isn't responsible for your movement of your spine. Your disc is just responsible for the support of the spine, okay? All the artificial discs that they have out there right now, there's some that are in FDA trials and things that are going on, but all of them that are there now almost work like a joint replacement. So they've kind of got this little ball area that sits up here, and they've got this little area that sits in on top of it that will allow movement to occur, okay? Well, that's not really what a disc does. A disc just supports. It doesn't actually promote movement in the spine. That movement comes from your facet joint. So if I create too much movement sitting in there, I actually have more of a problem than having a fusion and not having any movement at all. Okay? So from that standpoint, we have to be careful. Sally? So we have to be careful as to what's going on. You guys have that all in front of you, don't you? Mm-hmm. Okay, good. So if we lose it up there, we're okay. Just time.
There it is.
Aha! Wake up. My computer went to sleep at the same time too. So it must have been. So from that standpoint, artificial discs are not. Fusion, you're going to run just the opposite. Okay? So in a fusion scenario, you're asking an area to literally not move anymore, to lock into an open position and not move anymore. In single levels or two levels, from a standpoint that you're looking at a very, very small level of fusion, the majority of your movement still comes a lot from the paraspinous muscles. Okay? So from that standpoint, a lot of patients will tell you they don't really lose much mobility. Most of them will kind of gain some mobility because now the mobility doesn't hurt. So their decreased range of motion because of pain, that's gone. So they have a better increased range of pain. Now, I will tell people things that, people that I worry about are that, people that are, gymnasts, dancers, those type of things that have to do some very different movements with their spine. If I have a 3-level fusion in my back, can I do a back bend? Can I go back to doing gymnastics? Those type of things are a little bit difficult, but for the most part, fusion becomes the 4-letter word to your patients, okay? But it doesn't have to be, right? Congenital issues that we're dealing with, obviously, Quasimodo's, kyphosis in the thoracic spine, scoliosis are things. This is actually one of our patients. So scoliosis from there. Scoliosis, remember, can come two ways, whether we're talking about, kind of congenital scoliosis in kids that we're dealing with, or more of a degenerative scoliosis in your older patient that, the bone breakdown and the osteoporosis and all that kind of stuff is causing that patient to kind of fall over on itself. And those can be treated multiple ways, too. Bulging discs, herniated discs. Lumbar spine, cervical spine, obviously. So when we're dealing with from a standpoint, so, these are good discs, okay? Nice and white. This is a T2 image on an MRI. So on a T2 image, we're going to look at water, okay? So water is white. Remember, when you look at a disc has two components. Annulus on the outside, cartilage, like ear, nose, holds the shape. The inside's the nucleus pulposus. That's that white that we see. That's where that fluid is. When it becomes degenerative, okay, you lose the water out of it. All right, so these two levels are degenerative. This one then has a herniation on it. Just like playing with Play-Doh or playing with those balls, you squeeze them enough times, it doesn't come back to where it should. Now, you can have a protrusion or an extrusion, okay? And that's really important when you're dealing with patients, because remember, an extrusion just basically feels like you just took a piece off and just chipped it off and it's out there floating around someplace, okay? An extrusion, sometimes people can get better from those. I mean, the body's going to wall that, it can get to a place, the body will wall it off as a foreign material and just desiccate it and make it go away, okay? A protrusion, not so much. Also, when we're looking at surgery, from there, if we're doing a discectomy on a patient, if we're going in for an extrusion, that's really good. We're just going in there to try to find that piece that's floating around in there. You pull that piece out, you don't disrupt this disc structure, okay? Because you've got it through and that disc structure is healed. If we're doing a protrusion and you're doing a discectomy on a patient, you've got to actually disrupt the annulus to be able to get part of the nucleus pulposus out of there that's causing the bulge. That means that I'm looking at a good 4 to 6 weeks to heal that annulus back up again, or you're going to have a patient that continues to re-herniate. So you have a lot of those people that'll come in and, it's that 22-year-old that decided couldn't wait for the dolly and picked up the refrigerator and just and moved it and herniates a disc. And then feels better 5 minutes after surgery and goes out the next Saturday because, hey, I got a golf tournament, plays golf, and boom, re-herniates it right back again, okay? So these patients, you've got to tell after a discectomy that, behave, because, even get constipated. I even tell people from a standpoint, you're taking pain pills after surgery and you get constipated, and you sit down and, push really hard to have bowel movement, you're going to re-herniate. So be really careful with these patients. Obviously, herniated discs in the neck, you got to watch out for from a standpoint. When you're dealing with the neck, you're dealing with the spinal cord. Remember, when you get past L2, L1, L2, and you get out of that conus region, and you're in the you're down in cauda equina, okay? There's more space in there. You can have a huge herniation that's sitting in there that you look at it and go, oh my God. And the patient's like, it doesn't hurt. It doesn't bother them at all. But in the neck, you got to be careful because you're dealing with the spinal cord. We'll talk about spinal stenosis in a minute. Obviously, when we're looking at this, axial versus radicular, just like anything else. If it's just axial pain and they're not having radicular symptoms, they don't have any red flags, treat them conservatively. If they have radicular symptoms, you can still treat them conservatively if they don't have serious gross neurologic changes, okay? If you look at them and they come in and you look and their hands have just been completely deteriorated, or they have hyperreflexivity, or they have symptoms that look like they have cord compression, don't play around with those people, okay? There's something wrong. Figure out what's wrong first, and then figure out how you can treat them. But, if they're like, I fall asleep at night, and when I sleep and I got my arm up like this, I wake up at 2 o'clock in the morning and I got to shake my hand out because my hand is asleep, okay? But the rest of the day I'm fine, all right? Those people, you can try some things on and mess with them for a little bit and see what you can do to make that get better, okay? But if they have true neurologic signs, be careful. So watch your dermatomal patterns, check their strength, see what's going on, look for muscle atrophy, check their deep tendon reflexes to see. A lot of patients will come in with leg issues, and we'll talk a little bit more about that when I hit cervical in a bit. A lot of people will come in because they can't feel their feet, or their legs hurt, or they're walking weird, or they're doing things from a standpoint of that they'll come in, and everybody's worked them up for the lumbar spine, but nobody's done a check on them to find out that they have cord compression symptoms, okay? If you've got cord compression symptoms, there's a really good chance it's not lumbar spine. It's somewhere where there's a spinal cord, okay? So be thinking, start looking and start thinking up above that lumbar spine. Even though they're complaining that something's going on in their legs, be looking at other things because they're there. And we have a million patients a day that come through with leg issues. And I see them walk down the hallway and I went, whoa, that's a bad gait. And you walk in and the first thing you do is check a reflex or check a Hoffman, check a Hoffman sign. And you're like, okay, I'm going to send you to go get an MRI of your cervical spine right now. And they look at you and they go, well, my neck doesn't hurt. I don't care. You know, I'm going to send you because they've got cord compression. So even if they're complaining of something else, if you do your physical exam, you know there's no spinal cord in the lumbar spine. So you can't have cord compression symptoms there. Okay? Again, treatment, we've gone over this a billion times. NSAIDs, avoid narcotics. Neuroleptics, gabapentin, Lyrica, amitriptyline, Cymbalta, you know, those type of medications are good medicines, okay? But watch the TV commercials. You know, they have, here's what happens with the medication, and then the next 60 seconds on the commercials are the side effects associated with the medicine, okay? So these medicines don't come without problems. People will say, you know, my doctor put me on gabapentin, and now they've increased my gabapentin to 2,600 milligrams a day, okay? But I've put on 22 pounds in the last year. Yep, that's what gabapentin does, okay? So then you just went from, I said, and does it help? Well, no, not really, okay? But now they have the weight issue to go along with it. Now they've raised their BMI, and so now they have the weight issue to go along with it. So short-term effects of neuroleptics, you know, try them. Start low, increase slowly, those type of things. See if it's working. If it's not working, don't keep them on it, okay? One thing about neuroleptics, your patients will come in most of the time and say, well, I take gabapentin as needed, okay? Gabapentin really doesn't work that way. So, you know, I look at it and I say, well, when you take it, what happens? So I take it, and about 30 minutes after taking it, the numbness and tingling goes away. It shouldn't work that way, but patients will swear to you it does. Okay. Conservative pain management. Do I get epidural steroid injections, selective nerve root blocks, facet ablations? You know, none of these are going to cure the situation, okay? Really, if there's an anatomical structure that's wrong that's causing pain, the only thing that you can do to change that anatomical situation is to fix the anatomy. And pain management is not going to do that. But if it keeps them out of pain, and their neurologic symptoms are okay, and their neurologic exam is okay, and it's working, that's fine, okay? Again, they do not come without risks. So sticking a needle blindly into somebody's spinal canal and injecting a bunch of fluids into there, okay, doesn't come risk-free. And if it's not working, don't do it. Okay? So I can't tell you the number of people who come in and say, well, I've had epidural steroid injections, probably 6 of them a year for the last 10 years. Do you get any relief? Oh, for about 24 hours or so, I feel fine. One of the medicines that they put in there is Marcaine. Okay? So for 24 hours, you got relief because you had a bunch of Marcaine stuck in there. But the injection didn't do anything. And now the steroids have caused epidural lipomatosis. They've caused, you know, you've got steroids that are in around the bone, so now you've got osteoporosis. You know, you've got all these other things that you're dealing with because of what's going on. Selective nerve root blocks, they're really good if you have a nerve specifically that you want to look at, okay? But let me tell you, unless somebody does it under anesthesia, which really isn't good because you don't know if you have the needle in the right place. Selective nerve root blocks, your patients won't like you. They'll come in and say, that hurt. And it does because they're sticking the needle right up against the nerve. And since they're doing it usually maybe under an ultrasound or under a C-arm or under something from a standpoint and they can't really see where the nerve is, they're doing it blind, okay? Chances are they're going to know they're right up against the nerve as soon as the needles hit the nerve and it causes that zing to where they're going. They're like, oh, got the right spot. And then they inject the medicine in and hopefully the numbness of the medicine works quick enough that the patient hasn't jumped off the table yet. But they're painful, they hurt. Radio frequency ablations where you actually burn off the medial branch. So you have the nerve that comes out, right? And you got a little itty bitty branch that comes off that main nerve that goes to the actual facet joint itself. And you're going in and you're trying to ablate this nerve. Well, you don't want to ablate this nerve because this nerve is the nerve that goes down to the muscle, okay? So you don't want to kill it. So a lot of times what you do is they'll go in and start sticking needles in there, figure out if it causes you pain, then they know they're against the nerve that's heading down the leg or heading down the arm. And that's not the nerve they want to go for. So not benign issues. They kind of hurt. Surgery, I can't tell you the number of people who come in and say, well, I was at the Laser Spine Institute. Laser surgery works for very few people, okay? They're on commercials all the time. You walk in with a 1-inch incision and you leave, pain-free, okay? If it works for you, great. I'm telling you, the majority of insurance companies don't pay for laser surgery. The Laser Spine Institute here doesn't even take insurance. So they'll see your MRI for free, they'll consult you for free, but your surgery will be $60,000. So from that standpoint, I always tell people, hey, as physicians or as PAs or as whatever, we're no different than a mechanic, okay? You're not obligated to come see me and not go see anyone else. If you want a second opinion, you want a third opinion, you want a 10th opinion, I don't care. Go, the more knowledge that you have, the better decision you can make, and I'm okay with that. So if they say, well, I'm going to go talk to them, I'm like, okay, that's fine. But I will tell you, they're doing fusions over there now, okay? And their fusions, from a standpoint that it's not a hospital. So they have a contract with the hotel across the street, and they put the patients over in the hotel across the street, and they see them the next morning. There's no nurses in that hotel across the street. So it makes me nervous as can be that they're doing, that they're doing T-lifts and then they're sending patients across the street for the hotel through the night, and I'll see you in the morning. So, but
they got a good commercial.
But they have great commercials. They have great commercials. And we're sitting in the doctor's lounge at Saints, and that commercial comes on like every hour, and we're like, really? Foraminotomies, hemilaminectomies, discectomies, obviously less invasive surgeries work really good in a population of patients. So as you're looking through that, we've got to determine, are we just going to open up the foramen where that nerve needs to come out? Okay, is that just tight, and we just need to open that hole up a little bit to allow that nerve to come through? And in some patients, it works great, cervical or lumbar, works good. Hemilaminectomies or laminectomies. Do we just need to take part of that lamina off and just reduce some of the compression to the spine? In a certain population of patients, that's fine. Discectomies, again, if you're just going to go in a certain population of patients, that's fine. But you've got to remember that anytime you change or do surgery on something and you change someone's anatomy, what can be the risks or the downfalls of that later? So even though we're doing some of these, people tell me, is it a total cure? I can't guarantee you that, okay? Can't guarantee you that in 3 years you're going to be back again and we got to do a different surgery. Disc replacement, we kind of talked about a little bit more. That's the motion preservation or fusion, okay? In a fusion area and that's just going to depend on, what the patient wants, what the quality of life is, what's happening there. Spinal stenosis. This is one I probably see a lot. Usually in your older patients, okay? And I will have to admit after almost 20 years of this, doing surgery on these patients is probably one of the most productive surgeries that you can have. So if they have spinal stenosis, and if you've tried everything else all through the years and physical therapy and aquatic therapy and all these kind of things, and it's just gotten to the point where their patients are just flat miserable, they do really well in surgery. I mean, we get 80-year-olds that come through that you think, oh, this is not going to be good. The next time you see them, I mean, it's the happiest that they've been in years. But what we're looking at is the fact that there's just not enough room back here for these nerves to go through. When you look, I think I have a, yeah. When you look at these patients, this is what you're going to follow, okay? It's a progressive disease. These people have had pain for a long time, okay? And it's just gotten worse and worse and worse and worse as it goes to the point where they are incapacitated. Most of them will come in on walkers, rollators. I've had a couple on crutches lately. I don't know why they're on crutches, but they said it's easier for them to get around. A progressive decrease in their ability to ambulate. Who knows what a shopping cart sign is? Actually, a neurologic sign, you can actually find it out there. My kids, when they were little, they're all grown now, but when they were little, used to scream at me at the grocery store, Mom, don't say a word, you know, from a standpoint. Because you see these people walking around and they start pushing the shopping cart around everywhere you go, and then you see them in the next aisle, and they're like this on the shopping cart, and then by the time that they make it to the checkout, they're like this on the shopping cart. They're literally laying on top of the shopping cart, okay? The more forward flexion that they have, the more they're opening up that spinal canal, and they're able to go just a little while longer. So all of these patients, I go, most of them you will find out what makes it worse. When I stand too long, when I sit too long, when I walk, okay? What makes it better? When I rest, when I lay down at night, I don't have pain at night when I'm laying down, I'm good. Or I'm sitting in my recliner watching the football game, I'm fine. Okay, but boy, the minute I get up, it starts to hurt, okay? And it's better in forward flexion. So even my farmers who come out and who don't go to the grocery stores because their wife does, okay? I said, so when you get tired out in the fields, you lean against a fence post or lean against the pickup, or you're doing something, they're like, yeah, okay? So that forward flexion gives them just that little bit more as to what's going on. One of my favorite patients at the VA was horrible. I mean, he had this, everybody know what a spaghetti sign is? You know, you block off the nerves enough in a cauda equina that you look up above. You usually see those nerves coming down through, and all of a sudden now you see this just crinkle of nerves that sit up above that herniation. Well, the herniation's so bad that the nerves can't even come through, so it's like putting spaghetti in through a strainer that you just, you know, the rest of it just stays up here and into that strainer, and it just looks like this mesh web of nerve roots that are sitting up there because they can't get below it, all right? And we'll see that a little bit when we talk about cauda equina syndrome. But where was I leading with this? Oh, he had a chicken coop outside of his house. And his only goal in life was that every day he had to feed his chickens. Okay, fine. Okay, I would see him every year. You know, how are you doing? How are things going? I saw him for other things too, because he had Parkinson's disease and a couple other stuff that was going on. He's a vet. I mean, he's a veteran. He's a crazy Vietnam guy. But I finally one day said, are you sure things aren't getting worse? Are you sure, you know, you still feeding the chickens? Yep, still feeding the chickens. Okay, so are you sure everything's okay? Yeah, I'm fine. One day he brought his grandson in with him. So I looked at his grandson and I said, so is he still feeding the chickens? And he said, yeah, he feeds them every day. I said, good. So he said, are you having any problem getting back and forth from the house to the thing? Well, no, not anymore. Not anymore? What do you mean not anymore? He went, in 5 years' time that I knew him, he went from one chair between the house and the chicken coop to 16 chairs between the house and the chicken coop. So he could still feed the chickens every day, but he had to stop 16 times along the way. And his version of doing that was, well, I'll just take one of those chairs and throw one of the chairs out there. So he would put chairs out there, and he would walk from one chair to the next chair to the next chair to the next chair to the next chair. We did a laminectomy on him 2 weeks later. Chairs were all gone. I mean, but he refused. Yeah, I don't want a fusion. You don't need it. You know, if we could just open those nerves up a little bit, you know, you'll be fine. And so he went from one. So in all this time, I kept asking him, "Are you sure everything's okay?" "Yeah, everything's fine." 1 chair to 16 chairs. How do you treat these people? Water therapy works great for these people initially. Water therapy is awesome for core work. You know, the only way you can stay up on top of water is to have a nice strong core. So, and it doesn't affect your joints, and it doesn't matter how far you go, and it works all your muscles. It's really good. Epidural steroid injections initially do really well on these patients, but what you find is I used to get 2 years worth of relief. Then I got 6 months worth of relief. You know, now when you give it to me, I'm actually worse. Epidural steroid injections can actually cause epidural lipomatosis, which is a collection of fat that sits back there, okay? Just like it can cause a hump on your back from, you know, excessive steroids and stuff like that, it's going to cause it in the spine too. So when you look at that, now you have a stenotic area that used to be this big, and now it keeps getting smaller and smaller and smaller, and you're throwing fluid in there on top of it. Eventually what happens is the patient says, "I got an injection, and oh my God, that pain after the injection was horrible." Okay? The space is so tight, just trying to put fluid into it actually causes them pain. Don't send them for any more injections. Chances are they won't go for any more injections, but don't send them for any more. Decompressive laminectomy versus decompression infusion. I mean, that's going to be based on your patient population. I mean, you know, this guy was an older guy. He's, you know, he was thin. His bone wasn't great. He's probably not going to want to, you know, start working on trying out for the marathon. So we can do a 2 or 3 level decompressive laminectomy on him and not stabilize him and not really worry about causing some iatrogenic instability in this patient, because he's probably not going to do it. You get somebody who's in their 50s or 60s who has it severe, who is a runner, or who, you know, wants to get back into a very active lifestyle. You do just a decompressive laminectomy on it, cause instability in the spine. You're going to get spondylolisthesis after that, okay, because you just took away a bunch of structure, and you're going to probably have to bring them back to stabilize them with hardware. So sometimes you just have to look and see, you know, what I want to do with these people. Cauda-Equina syndrome, emergency. Okay, true emergency. You get patients that are like this, send them to the ER, or if you've got good contact with a surgeon, call the surgeon on their phone right away and tell them what you've got going on. This is when, I guess I don't have a really good picture in here, but typically, you know, you see these nerves that are coming down through here like this. You get a true cauda-equina, you'll get a nest of nerves that just will kind of sit right here on top of this because they just can't get through, okay? So these are people who, lower extremity weakness, I mean, they can, you know, a lot of times they're being carried in, or they're in a wheelchair, or they're, you know, they can't use their legs. They don't even know their legs exist, okay? This is also when you're asking them about bladder stuff, you know. Do we have bladder retention, urinary retention, or urinary loss? Do we have total loss of bowel habits from a standpoint? Or do you have saddle anesthesia? Okay. If you have these type of components that's a new onset, it just happened today or yesterday, that needs surgery tonight. Okay, it can't wait. I already went through all that. So the other one that we've got to look at too, again, like I said before, is this. So you've got the patient that's a new onset of they can't lift their foot. Okay, their foot's just dragging. Another one of those deals that's not something, oh, well, let's just watch it for a little bit and see if we can do some steroid injections and see if we can get it better. No, a surgeon needs to see that patient, because if there's something that we can get off that L5 nerve root, we got to do it. We got to do it now, or they'll lose that ability to move that foot pretty fast. This is the one that I kind of that I kind of talk to. We see this a bunch, and they weren't sent for their neck. This is something that's when you're out working and when you're out doing things, a lot of times these people, because it develops so slowly over time, they won't tell you what's going on. But kind of key things to start watching for is these patients. One, they're going to complain to you if they put their head up, if they look up, okay, to do anything. They may get shocks. Okay, so they may tell you that I don't do anything up here anymore because every time I put my head back, I mean, it's literally like they just stuck their finger in a light socket. I mean, they get that electrical bolt, okay, because they come back and hit the cord. But most of the time, what they start talking about is their clumsiness, their inability, they're dropping things. They can't button their shirts anymore. They can't zip up their jeans. They can't do things. This has been going on for a while, this compression to the cord. Okay, sitting up here, this has been happening for a while, but it's finally starting to cause them issues. So when people are talking about the fact of, I can't feel my fingertips, it's not usually dermatomal. I mean, it's not like, oh, it's just these two fingers. It's like, I can't feel anything in my fingers at all. They'll lose proprioception in their feet. Because remember, it's your spinal cord, it's got all your nerves, so they'll lose a lot of them in their feet. And a lot of patients, I'll tell them they have problems with getting up in the middle of the night to go to the bathroom because it's dark. Okay, remember, vision kind of helps you see where your feet and where things are going, so you know what's happening. So as you watch where you're walking, you know that you're not going to stumble or trip over anything. But if it's dark and you can't feel the bottom of your feet, okay, you're gonna fall. But these patients always come to us with this really almost a cerebral palsy gait. Okay, they are bouncing from wall to wall. They're not doing that antalgia gait where it just hurts. They're not limping as they come in, but they literally, that they can't. They have no idea where their feet are on the ground. So they are just all over the place. And they'll send them because, oh, they must have something going on with their lumbar spine. And it's, no, they have, they have this cervical stenosis. Muscle atrophy, the biggest muscle atrophies in these people is just, put your hands out. Let me look at your hands, okay? Almost always, this will be gone, okay? Intrinsics in their hands will almost always be starting to shrink down. Those patients, I always tell them, from a standpoint, you may not always get that back, okay? But we're going to prevent it from getting worse, or we're going to decrease your risk of this, okay? These patients who don't want to have surgery, I always look at them and say, okay, that's fine, I get it, you don't want to have surgery, but here's the deal. Don't shovel snow uphill, okay? You'll end up like Dean Blevins and in the emergency room and in ICU because you fell over backwards and hit your head, all right? You're going to be paralyzed. Don't be an aggressive driver. Somebody's tailgating you and you get really pissed off and you hit your brakes and they hit you from behind, okay? They're going to walk away from the accident. You're not, okay? So these patients, we really have to watch for signs of paralysis, and we really got to talk to them. If this keeps getting worse, if we start doing things, you got to fix it, and surgical is the only way you can fix it. If it's multiple levels, you may have to do it posteriorly and anteriorly. Patient's going to lose range of motion big time. If it's just a few levels, like this patient was, we were able to actually go in and do just a couple of these discs, and we were, the patient was okay. But these are the patients from a neurologic standpoint. These are your physical exams that you've got to pick up. So even they're talking about their gait's funny, and you're looking at things. All of a sudden now you check their reflexes, and you snap them, and they fly up. You hit their knee, and they kick you across the room. Okay. Remember, a nerve compression is going to decrease deep tendon reflexes. Okay. So instead of having a 2+ DTR, you're going to have a 1+ DTR if you hit a peripheral nerve. Okay, at a specific nerve rate. If you've got cord compression and you're dealing with spinal cord issue or a brain issue, you're going to have hyperreflexia. Okay. Decreased proprioception in the hands. That's just talking to these people. I mean, can you button your shirts? And they'll come in with polo shirts on and they're like, I never wear a button-up shirt anymore. Why? Because I can't button. How long has that been going on? Last 2 or 3 years. Okay, something's wrong. If you can't use your fingers, something's the matter, you know? Why alter what you do versus that? We always list this myelopathic gait as a drunk gait. I mean, these people they're just all over the place. You just watch them, and a lot of them are up on their toes. They don't put their feet all the way down, and you know they literally walk down the hall to go to the X-ray, and Scott and I look at each other and go, get us a picture of the neck while you're there. Hyperreflexibility we talked about. Everybody know what Hoffman's sign is? No? Okay. If you flick this finger, okay, these fingers shouldn't move if it's normal. Okay? So if I grab a hold of this finger and I sit here and flick these fingers, I should be able to. You flick a person's finger with a cord compression or with a brain disease, okay, they're going to do this. Okay? And you'll see it's really crazy the first time you do it. And our patients, when they come back every time on their post-op, the first thing I do will grab their finger and start flicking their finger, and they'll look down and they'll go, oh, it's not moving anymore. You know, because they've gotten so used to us constantly messing with their fingernail when they come in. But that's there. But I mean, and it's obvious. I mean, you do it the first time, and that's the minute they walk back from X-ray. If they walk past the nurse's station, right where we're usually standing, before they even walk into the room, I'll say, can I see your hand? And they'll be like, huh? And they'll just, kind of hand me their hand. One, I'm looking for atrophy. And two, I'll do a quick Hoffman's. And it's like, oh, there you go. Done. You know, the exam is done. I don't have to do anything else because they had that. That's where it is. Surgical urgency. These patients, I've had several in the last, year or so that have put it off and put it off and put it off and put it off and put it off. And every time they come in for follow-up, I don't push surgery. Our office doesn't push surgery on anyone, okay? But every time they come in, I go through the whole realm again of this is not going to get any better, it's going to get worse. It could get to the point where we start to see signal changes inside of the cord. Okay, I tell people, every time you throw your head back, every time you do something, it's just doing this to your spinal cord. Okay? That's fine. If I hit you once on your leg, you're going to look at me and go, ow, that hurt. Okay? But if I continue to hit the same spot on your leg over and over again, it's going to bruise, it's going to become permanently injured. If you get a signal change inside of the cord to where you've actually permanently injured that cord, doing surgery and treating it from there is going to hopefully prevent it from getting any worse. But remember, that's your central nervous system. It doesn't heal. Okay? That change in the cord is going to be there forever. And there's the likelihood that some of the symptoms won't ever completely resolve and come back. So the longer they wait, I always tell them, the longer you let that progress, the more chances that we're going to have of not getting you back to where you were. And that comes with pretty much anything in orthopedics. I mean, people wait, have total knee or a total hip or one of those type of things. And, if you're a really athletic person and a really good person that wants to do a lot of stuff, you wait too long, there's a chance is that you can do that replacement and you're never going to get back to the same quality of life that you had before, that you expect to get from it. So there becomes a time at any point in time that this is not something that we sit around and wait on. Obviously, treatment for this is going to be surgical. So whether or not you have to do it from behind or can do an anterior cervical discectomy. Does anybody know what the corpectomy is? Can I go back? If you go back a couple of things where the cervical spine is, sometimes it's not just the disc that's protruding back, or if it is the disc has come in behind a vertebral body and you can't get to it, that's causing the compression. You actually have to take out the entire vertebral body. Okay, that anterior portion of that vertebral body, we just basically take a Dremel diamond drill bit and just take that all the way down until we get almost to the cord, and then slowly just peel the remainder part of that off the cord. And sometimes you have to just take it. We then put like a titanium cage that falls into that full space that falls in through there. So if it's the bone that's causing the compression, You can't just correct it by just doing a discectomy and taking the disc out. You actually have to remove the entire vertebral body. Does not change the ability of the patient to do anything, does not change their course of healing, doesn't even change much time of the surgery. You know, so it's not a big deal. And most of those patients I go in and tell them, I said, this may be an intraoperative decision. So their consent will say a C4 to C6 ACDF with possible C5 corpectomy. And they'll go, well, when will we know what happens? And I said, when you come out of that, when you wake up in the recovery room, because we don't even know while we're in there as to whether or not you're going to be able to get that all out of there, or whether or not the best thing for this patient is just to take out that vertebral body. But they do well. Last bit into their fractures. Compression fractures, they're most common. Most of the times you'll see these in little old ladies, or you will see them in accidents. You may see them in multiple myeloma, which we'll talk about in a second. But you'll be able to see most of these and all those kind of things. I won't go through most of these fractures because you won't see very much of them. Jefferson fracture is a C1 fracture. So this is this is a compression fracture that's sitting in here. Steroid use, we talked about that a little bit. It's really common, kind of, you know, somewhere between about T11 and L2. You'll see them a lot in that area. Most of the time it's a pinpoint pain. I hurt right here. A lot of times you can fix these by, you know, if it's a little old lady with osteoporosis and they haven't been through a DEXA scanner yet, and they haven't been on any kind of medications to help with osteoporosis, you can do that for them, which they should have had done anyway. Sometimes you can brace these and they'll do okay for a while. Sometimes it just takes time, just like a sprain or a strain. Other times we've got to go in and do things a little bit more aggressively. With a vertebroplasty or kyphoplasty, sticking acrylic into that bone and kind of spreading that bone back out and seeing, you know, if we have some more strength to that bone, will we lose some of the pain associated with the bone. Sometimes it can cause enough damage that we worry about that we actually have to, you know, fuse the levels above and below that bone so that we're not getting a lot of compression to that bone and a lot of pain to the bone. But usually doing things more conservatively initially is the way to go. Jefferson fracture, it's a C1 fracture. The thing you have to worry about Jefferson fractures is where they're located, because if you get them out here, okay, what runs through that hole? Vertebral artery. So, you know, you can get disruption of the vertebral artery, so you've got to be really careful on some of these patients of looking at it. Sometimes you can deal with them with just, you know, just minor treatments, bracings and stuff from there. Sometimes you have to put them in a halo if they're bad neurologic symptoms. But remember, it can also disrupt the ligaments between C1 and C2 that's sitting up here in the dens. So you've got to really look for dens fractures and C2 fractures too to go along with it, because, you know, if they piff their spinal cord right here, they're not going to live. So, you know, sometimes it's halos, sometimes it's surgery, but it just depends kind of on what's going on here. But these are not things to play with. Adenoid fractures or dens fractures, again, 3 types. One comes through the tip, one comes through the base, and one includes the lateral mass. Obviously, type 3, that's a surgical deal, because if you get into the lateral masses, again, we're getting into the areas that were too close to the vertebral arteries, not to stabilize that, or this just falls off right here and falls right into your spinal cord, hits your spinal cord at C1, C2, and you stop breathing. Okay, so from that standpoint, you know, these are things that you know, they'll find usually on a CT scan, usually in the emergency room, usually after a fall, and we just got to take a look at it quick. Hangman's fracture, I don't know why they call it a hangman's fracture, it's a hanging's fracture. But these happen, you know, somebody hangs themselves, they have a disarticulation between C2 and C3. You know, C2 just falls right over the top of C3. If they've survived from that, because you got them down fast enough to get them to survive, then usually these are treated with halos. You stick them in a halo and run around from there for a while. Sometimes you have to go back in later and fuse it, but a lot of times you'll be able to do it from there. Teardrop fractures. The first one, that extension fracture, a lot of times you see in a car accident, that's a whiplash, okay? And what happens is there's a ligament, it's called the anterior longitudinal ligament, that sits right on top of the spine. C2, remember, it's got that funky bone that's got the little, it's got your dens in there. And this part that sits out here, that anterior longitudinal ligament sits right here. And if you do a quick whiplash, it will literally avulse a piece of bone right off the C2 that's there. Most of the time you can put these people in a collar, and a lot of times you don't even have to use an Aspen collar. You can use a soft collar on these patients, and they'll do better. Flexion, worse. These are your divers. So these are the ones that decided to go out and cliff dive over at what's the lake out on I-40? No, going out of town. That's got the cliffs on it. What is that?
Way out east?
Yeah, kind of halfway between here and Arkansas. Eufaula. Eufaula. There's a bunch of cliffs. There's a bunch of cliffs in Eufaula. And everyone loves to go out and jump off the cliffs and stuff like that. And then you got the one idiot that decides they're going to dive off the cliff and gets this, flexion axial loading. So that, head going in rapid motion, head stops. Okay? It's not the rapid motion that hurt it. It was the stop at the end that hurt it. And these patients mostly are going to be paralyzed. Usually those paralysis are going to be 5-6. So typically they've got some shoulder ability. They've got some stuff here. Sometimes they have a little ability in their hands to grip things and hold things with a lot of therapy, but most of the time they're shoulders down. Chance fractures. These are the ones that are seat belted. They have that seat belt that runs across here and comes to that rapid stop, and you've got the second half of the body that stays where the bottom lobe of the body that stays where it is, and the upper body that goes like this. Okay, and you get kind of this fracture that sits back there. Most of the time you don't have to fix them. Most of the time they'll heal on their own. You put them in braces and stuff, they'll heal. Okay, and we don't have to worry about it. The biggest thing you have to worry about that is if you see that, you better be looking at making sure they don't have an inter-abdominal problem someplace, that they haven't ruptured a spleen, they haven't done something to one of their arteries, that they don't have a kidney problem, because these patients, they've been smacked hard enough that if they've done a chance fracture, that chances are they've got an abdominal problem someplace. Burst fractures, compression fracture that just does exactly what it sounds like. It just blew up, okay? Sometimes you can brace them and they'll do okay. Almost all of them we brace initially and give them a chance unless they have neurologic symptoms. We brace them and just let them go for a little bit and see. But if it's been 6, 8, 10 weeks that these patients the pain is getting worse and things are getting bad, you've got to go in and fix them, which is a fusion. Coccyx fractures, you see them all the time. I was playing around doing something and I fell flat on my butt, okay? And you get a coccyx fracture. Sorry. Donuts for a while you're sitting, fixing them. You can do a coccygectomy. You can go in and actually take out the tailbone. I guarantee you 100% of the time you will have an infection. And it is horrible because then you're walking around with a wound vac for 6 weeks and you're on IV antibiotics, okay? Think about where your coccyx is, okay? Trying to do any kind of surgery in there and keeping yourself clean, not possible. You will have an enterococcus infection, I can guarantee you. We used to do them quite a bit, and I came in and I was like, every single one of these we do, we have an infection. Why do we do this? And then all of a sudden we're like, oh, maybe we shouldn't do this anymore. We don't do them anymore. So these are the last 3%, and I'll get through this really quick and we'll go. The last 3%. People come in with back pain. Don't always think that it's just the back. Okay, remember there are other things that cause back pain. So be thinking about, do these patients have a AAA that's getting ready to burst? Pelvic disease can cause back pain. GI disease, pancreatitis, you know, probably I don't know how many patients, and not even patients, but friends recently who have had pancreatic cancer. You know, their first complaint was back pain. That was their first complaint. And, you know, people started working up all this back pain and figuring out what was going on, and come find out that they've got pancreatic cancer, okay? Renal disease, kidney stones, where's the first place it's going to hurt? Pyelonephritis, where's the first place it's going to hurt? You know, those type of things. So don't get so wrapped up if somebody says that they have back pain that it has to be coming from their back. It can be coming from other things, so be careful. Non-mechanical, the last bit of it, obviously we're always going to be thinking about cancers, and then some of your arthritis issues too. And I put those in mostly because I just took my pre-certifications, okay? Guess what was on it? Ankylosing spondylitis, okay? I don't think I have ever taken an exam, that was my fourth, and I don't think I've ever taken one that hasn't had an ankylosing spondylitis question on it, ever. Multiple myeloma, plasma cell, going crazy. These patients come in with funky bone pain. I mean, it's usually in the spine, but it's really weird. I mean, it's just weird. They can have a lot of changes in what's going on in their blood chemistry. They have an increase in osteoclasts. So when you have an increase in osteoclasts, you have all this breakdown. They have hypercalcemia. So you come in and they've got all this calcium in. Then it can lead to multiple things: infections, kidney diseases. Multiple myeloma is not a fun thing. I've got a picture in here to kind of show you a big one as what's going on. But you know, looking at the fact that typically on these patients, get an SPEP, you know, get a blood from there, and then the thing you will always see from a board standpoint are going to be those Bence-Jones proteins in the urine. You know, those patients. You'll see that somewhere in the thing, and then all of a sudden one of the answers will be multiple myeloma. If it says Bence-Jones, go for multiple myeloma, because that's what it is. So this is what it looks like. So all this, you know, bone should be a consistent look on an MRI. I mean, it may be osteoporotic, so it's not quite as pretty, but it should always have consistent. When you get this modeling appearance that's coming in the bone, something's not right. Okay, so those patients need to be, and literally they come in for pain, nothing else. I mean, that's all. They can't. It's not neurologic. It's not radicular. You can't find it anywhere. They just have chronic back pain, and they come in and their MRI looks like that. Metastatic tumors. Third most common site for a metastatic tumor is the spine. So you'll see a lot, particularly breast cancer patients will have a bunch, lung cancer patients and colon cancer patients. Those are the ones that you will see the most. The majority of the time, not a lot you can do for it. Radiation, palliative radiation. I mean, remember now these patients have gone usually into kind of a stage 4 cancer scenario. You know, if we started hitting meds. They like to hit the thoracic region. I don't know why, but they do. Treatment, like I said, radiation. Obviously, you know, if it has something from a standpoint that there's a met there that's caused a compression fracture around the met, or a burst fracture because of the met, or the met is actually grown out of the bone, and you actually have it invading into the epidural space, or invading out the spinous process and invading into the soft tissues of the paraspinous musculature and stuff. Sometimes you have to go in and kind of debride that for nothing more than to just help the patient feel better. But it's not going to cure it. I mean, obviously that's, you know, you get to that point in cancer and it's not looking good. And then just a couple of tumors. You guys can read through this because I don't think I've ever seen anything on any boards. Maybe a sarcoma, but hardly ever do you see anything about spinal cord tumors. Most of the ones that sit outside of the spinal cord, okay, are benign. You know, it's just a growth that's kind of occurred on a nerve root. Sometimes they get big enough and large enough that they cause compression to the nerve root. going to a neurosurgeon. Okay, we're an orthopedic spine. Don't send us nerve tumors. We don't play with them. Okay, but going to that's when I find a big difference between, do I send him to an orthopedic spine specialist or do I send him to a neurosurgeon? You see these type of things, they need to go to a neurosurgeon. Okay, sometimes you can fix them. Sometimes when you fix them, or when they fix them, don't forget they totally damage the nerve root that they're attached to. So, be sure that you're going to realize that that patient's going to come in with a paralysis of a nerve root at some point or another, because where they took that schwannoma off, there's a good chance that they have a permanent foot drop after that. If it's sitting at L5, they've got something permanently wrong with them. But they don't have the schwannoma anymore. Intermedullary, inside of the spinal cord, those suckers are going to be malignant. Tumors, so here's some benign or malignant. This is the one probably, if you're ever going to see anything from on a board situation or a testing situation, it's going to be an osteogenic sarcoma, because these are teenagers typically, and it's that kid who's had pain, and it's pain all the time. It can be all through the night, it can be whatever. They may have had a fracture. A lot of them are found because they fractured. They're playing sports and somebody hit them, and that sarcoma that's in there has actually weakened the bone that's around it, and they now have a femur fracture, or they now have something from there, or they have a spinal fracture. So most of this you're going to see, but most of the time you don't. Even on board questions, they don't usually show them in the spine. They'll typically, this is a femur, or something that's something that's real obvious when you're looking at a question. But you can't forget it. Inflammatory arthritis, ankylosing spondylitis, we just talked about. It's on every board question. Okay, you really don't see it very often. In fact, I think I've had in 18 years maybe a dozen with true diagnosis of ankylosing spondylitis. Typically starts in sacroiliac joint, so patients will usually complain of sacroiliac pain before they complain of anything else. HLA B27, remember it, ingrain it in your brain, you will see it over and over again. Bamboo spine, these people can have eye problems, so a lot of times they'll have inflammation in the eye, so you'll see eye problems with it. Send these patients to your rheumatologists, because every time you turn around there's different treatments for it. So don't even start with really dealing with the treatment. If you get somebody that comes up in HLA B27 positive, ship them. Unless you're in rheumatology, and then take care of them. Other things that you got to worry about, just because you'll see them actually more frequently than anything else that's kind of associated with legs and spine and stuff, but it's not there. Trochanteric bursitis, you got a bursa that sits right here. Okay, patients will come in and it only hurts right here. Okay, that doesn't mean it's necessarily radicular unless it's going down the leg, or you get numbness and tingling in the foot, or something else that's going on. But their common thing is, I love to sleep on my left side and I can't sleep on it anymore. Okay, anything that touches right here hurts them, and it's likely just an inflamed bursa. You can throw a couple steroid injections in there, put them on some NSAIDs for a while, and usually they get better. Okay, sacroiliac pain. Remember, right here. Okay, sacroiliac is the only joint we have in our body that does this. Okay, women, big time, especially women who have gone through vaginal childbirth. Okay, because that whole pelvis has to change shape. Everything's got to change to be able to, ligaments loosen, everything to be able to pass that baby through. And so people will have pain along the sacroiliac joint. A good one on watching that, pain rotating inwards with your leg. So if I rotate my hip in, okay, is hip pain. Okay, that's something going on in my hip joint. Okay, pain that runs across the groin is my hip. Pain that runs on the outside of my groin is not my hip. Okay, your hip, think about where your structure of your hip is. That's an internal rotation. If I internally rotate my hip hurts. That's going to be a hip joint pain. Okay, if I externally rotate it, and I move that on an external rotation, I change the structure of what's going on here in my sacroiliac joint. So if you sit down and sit Indian style, on the ground, and you bring that leg out, do you have pain that runs right down through here? Okay, and that could be sacroiliac pain. So when you look at sacroiliac pain, usually physical therapy, things like that will help. Just stretching that area out, but you can also go in and pain management or our office, whoever, somebody can throw some injections into that sacroiliac joint, see if we can get that sacroiliac joint to come in. The other one that you'll see quite a bit of is piriformis pain. Remember, you have a whole series of muscles that come down into the pelvic regions, okay? Your sciatic nerve runs right in the middle of those muscles. So you get any kind of irritation to that muscle structure or inflammation in that muscle structure that's there, you can get pain that radiates down the back of the leg that your spine looks perfectly fine. Most of those patients will complain of only really pain when they're sitting. So pain when they have compression down into that pelvic region is where they get pain from. If you have a good pain management doctor, they can a lot of times do some work with that, but mostly that's going to be physical therapy and exercise. That's it. Questions, comments, concerns, worries?